Thulium laser vaporization of the prostate by Dr. Olufenwa Famakinwa and Dr. Doreen Chung. Laser modalities in the treatment of benign prostatic hyperplasia are safe and effective alternatives to the standard TURP. There is increasing utilization of lasers for minimally invasive treatment of BPH because of fewer hemodynamic shifts, less bleeding, and shorter hospital stay. Yu and colleagues analyzed practice patterns and found that by 2005, TURPs only accounted for 39% of surgeries done for BPH, while minimally invasive techniques accounted for 57%. The thulium laser was introduced in 2005 and has demonstrated excellent safety and efficacy thus far. The Cyber TM is a thulium surgical laser system made by Quanta System DNA laser technology. The 210 nanometer wavelength is similar to that of the helium laser, which is close to the peak absorption of water. Because the laser energy is quickly absorbed by interstitial water, its effect is not limited by the vascularity of the tissue. Furthermore, it has a shallow 0.2 millimeter depth of penetration, which is excellent for ablation of superficial tissue without extensive coagulation damage to deeper tissue. In the first section, we will demonstrate a methodical, simple technique of thulium laser vaporization, which is similar to the laser enucleation described by Tay et al. In the second portion, we will show our safety and efficacy data with this method. The setup includes the camera, 2 laser fibers at 800 and 1000 micron fiber. We've been using the 1000 micron fiber, 30-degree lens, the laser bridge, and a 26 French continuous flow cystoscope set, and normal saline irrigation. This is a 72-year-old gentleman with a 47-gram prostate and a post-void residual of 10 cc's with a Qmax of only 3 cc's per second. With the 26 French cystoscope inserted under direct vision, the bladder is surveyed and both ureteral orifices are identified. The prostatic urethra is examined from the bladder neck to the vira montana. This is a representation of the transurethral view of the prostate with trilobar hypertrophy. An 80-watt setting is used initially. The median lobe is addressed first with an incision at the 6 o'clock position, beginning from the bladder neck distally towards the vira montana. This creates a channel to facilitate continuous flow of saline, optimizing the visual field. The 6 o'clock incision is carried deeper so that the bed of the prostatic urethra becomes level with the trigone of the bladder. After the median channel is completed, the next incision is made at 5 o'clock, and the tissue between the 2 incisions is vaporized on a setting of 120 watts. Again, the incision is taken down to the level of the bladder mucosa. Periodically, the mucosa is briefly examined to monitor this depth and to inspect the ureteral orifices. To efficiently vaporize the tissue and minimize deep coagulation damage, the laser fiber is moved continuously, proximal to distal, with the light dusting contact with the tissue surface. Note that the lens itself is stationary except for very small pivoting movements. A counter incision is made at 7 o'clock and the intervening tissue is vaporized. This approach to the medium lobe allows the floor of the prostatic urethra to open up and further facilitates in the high flow of saline irrigation for excellent visualization. On a setting back at 80 watts, the lateral lobes are addressed starting at the left lobe with a 2 o'clock incision. Once the lateral lobe has been folded down, the tissue is then vaporized at 150 watts and then taken away from the capsule. Significant bleeding is rarely encountered due to the exceptional hemostasis of the thulium laser. Of note, the thulium laser fiber can be sterilized and reused. This differs from other laser fibers. The right lobe is incised at 10 o'clock on a setting of 80 watts, and the prostate is vaporized off the capsule at 150 watts, as was done with the left lobe. The back and forth motion of the thulium laser provides optimal, even vaporization. This differs from the sweeping motion of the green light laser. The intervening anterior tissue between the 10 and 2 o'clock incisions is vaporized, completing the procedure. At the conclusion of the procedure, the 2mm syringe will be used to manually irrigate the bladder to ensure that there is no bleeding. A 22 French two-way urethral catheter is kept in place for 1 to 2 days. Patients are typically discharged the same day after surgery. The saline flow is turned down low, and any visible bleeding is coagulated on a setting of 60 watts. The prostatic urethra is now wide open. The ureteric orifices are inspected one last time before the end of the case. We now present our 9-month experience using this technique. A total of 19 patients have undergone thulium vaporization with a mean age of 68 years, prostate volume of 68.8 cc's, PSA of 2.8, IPSS of 21.4, quality of life score of 5, Qmax of 7.0 milliliters per second, post-void residual of 209 milliliters, and a bladder outlet obstructive index of 64. 5 patients presented in urinary retention. 9 patients had concomitant urge incontinence preoperatively. All patients were either on an alpha blocker or 5-alpha reductase inhibitor, or both, before surgery, and 10 patients were anticoagulated preoperatively. There was only one mild complication in a patient who had initial urinary retention after the first trial of void. He is since voiding well since the second trial of void. There were no blood transfusions or major complications. There was no significant change from baseline hemoglobin or sodium after surgery. This is a table of the voiding parameters at baseline, 1 week, and 1 month. There is statistically significant difference in all the voiding parameters, including Qmax at 1 week and 1 month, post-void residual at 1 week and 1 month, and 1-month IPSS and quality of life score. Short-term results of the thulium laser vaporization of the prostate demonstrate promising results with minimal complications. Further follow-up is needed to evaluate its durability.